Welcome to this fourth module in our series on caring for people from a refugee-like background. My name is Rebecca, and this is a series of resources we've developed in collaboration with some colleagues of mine in Queensland, Dr. Rachel Clayton and Dr. Margaret Kay. This section is on completing the comprehensive refugee health assessment. And when I think about the refugee health assessment, for me, really this comes down to being, I guess, our evidence-based guideline that informs really all of the preventative care that we should be providing to people who have come to Australia as refugees. We very much recommend that it's something that should be completed in that early resettlement period, because there's so much evidence to show that if we can complete that comprehensive assessment and deliver good quality catch-up care in that early resettlement period, the long-term outcomes in terms of health and well-being are so much better. But having said that, and I think Rachel alluded to this in an earlier section, there is no standardised system across Australia to ensure that everybody gets this comprehensive assessment, in that early resettlement period. And I think we're getting much better. I think we've got some pretty good systems now, but for many years that hasn't necessarily been the case. And again, I've mentioned I'm working in Queensland, and there certainly has been a big period of time here in Queensland where we know lots of people didn't have access to this kind of comprehensive assessment. So for me, what we're going to talk about in this section, it really just sits there and again in the back of my mind as being all of the things that I want to consider when I'm seeing someone who's come to Australia, as a refugee, and just making sure that those things have been addressed at some point in time. And sometimes I'll be seeing somebody who's been here for 7 years, and I'll see that their screening investigations they weren't done, and this is a wonderful opportunity for me to do it today. So just sit there as a guideline for us. So I think before we start any health assessment, I guess the first thing we want to know is what health assessments have been done previously, what clinical information is available to us. And I think as we've reflected on Joshua's case throughout these modules, we've really seen, that a lot of that information will simply come from the patient and from their family and the concerns that they raise with us. Some of that information will come from our knowledge of refugee health more broadly, and the kind of the considerations that we know we need to be aware of. But it's also important to know where to seek any kind of clinical documents that may be available to us. So I just really briefly wanted to flag the pre-arrival screening and immunisation processes. I think, again, when I talk to colleagues, often people assume that somewhere along the way before people came to Australia, they had this really, really comprehensive assessment done. And so everything's kind of done and they can kind of continue to care for the patients here in Australia according to kind of all of our other guidelines, the Red Book, those sorts of things, without considering some of these other medical considerations. So I just want to highlight that basically offshore, before somebody comes to Australia as a humanitarian entrant, they will have had an immigration medical examination. That can be done up to 12 months prior to them actually travelling to Australia. So I think that's probably the first thing to recognise, that anything that was picked up at that time may well have changed in the following 12 months. I think you can also see from the slide there, just looking at what it contains, it's not the kind of comprehensive assessment that we're going to talk to in this section. It's more about ensuring that patients are well enough to travel, that we're kind of considering public health implications. So it's not something to be relied upon, I guess, as being a comprehensive assessment. We also need to consider that often these assessments are done under very difficult circumstances, in refugee camps with limited resources. So whether or not the degree to which they're able to be, completed, it can be variable. We then move to the departure health check. So this is generally done just before somebody travels to Australia. And again, you can see what's included there, physical examination, rapid diagnostic test for malaria and treatment if that's positive, empirical treatment of parasites with albendazole, an MMR vaccine, potentially a chest x-ray, potentially a yellow fever and polio vaccine, depending on where you are. But again, this is really just about making sure that people are kind of safe to get on the plane and get to Australia. So again, not a comprehensive assessment, and again, not necessarily done for everyone, because we have to remember again the circumstances in which sometimes people are leaving their countries. I think then people assume, so that was offshore, and we're recognising that sometimes there's been limited care at that point. I guess then people assume that perhaps if somebody had come to Australia and was in an Australian immigration facility, that then surely a really comprehensive assessment might have been done. And again, sometimes it can be difficult to kind of establish exactly what has been offered in immigration detention. But I think just to recognise that what we're looking at here is really about trying to keep people safe and those public health concerns while they're in that facility. So again, we're not seeing a really comprehensive assessment. We're seeing kind of public health concerns addressed, acute needs addressed, but not really looking at that kind of broader preventative health picture. And I think really important to recognise, again, when we're thinking about people who are in immigration detention, again, I've mentioned this before, but we recognise the profound impact that situation has on somebody's physical and mental health. So their ability to trust and build rapport and engage with healthcare services while they're in that situation can be very, very limited. So I think that means that there are some real constraints around the care that can be provided in that setting as well. So building on that conversation around the immigration medical exam and the departure health check, it's important to recognise that some of that information will be available to us here in Australia and how to access that. So generally it will be in a system called the Health Assessment Portal, or HAPLITE, which is a Department of Home Affairs system for sharing this information once people arrive here in Australia. The settlement providers in your local area will have access to something called a HAP ID, which is required to be able to access this information, and they will generally have links with your local refugee health services, so they'll usually be able to work together to be able to try and access this information, which can be really valuable for us as GPs in trying to provide care, recognising again that it's not necessarily going to be comprehensive, and I guess again sometimes there can be real limitations in terms of the actual documentation that arrives for us. The other thing that will be registered in that HAPLITE system is health alerts and health undertakings. So health alerts basically ensure that individuals with serious medical conditions are linked with appropriate medical services. And so basically at the time of that immigration medical exam, potential issues can be raised, and that can be recorded basically as a potential health alert. And basically, that identifies a serious medical condition that may require immediate medical follow-up after arrival in Australia. A critical medical issue is one that's either identified during that departure health check, or it may be that at that time that potential medical issue was then basically deemed to be a critical medical issue. And what that means for us as GPs here in Australia is that sometimes settlement providers, in collaboration perhaps with the Refugee Health Service, depending on the system in your state or territory, will be looking to ensure that people are seen within 24 to 72 hours of arrival for a medical assessment. The other thing to note is a health undertaking. So that's another sort of note, I guess, in that HAPLITE system. And it's basically an agreement between individuals and the Australian government to say that the person will follow up with a health authority after arrival in Australia. So again, that's something that sometimes those settlement providers, refugee health services, will really be trying to support patients to access care in that timely fashion to address that health undertaking. So now we come to the refugee health assessment, and as I've said, really recognising that this in many ways provides us with a really great evidence-based guideline that can allow us to provide that really comprehensive assessment that we know that the evidence shows us really supports our patients to achieve the best health outcomes long term. So this assessment should be offered to everyone from a refugee-like background, and as I said before, preferably within 1 month of arrival. But if that doesn't happen, as I said, this assessment still guides my practice years down the track. I'm still kind of, when I see someone for the first time, thinking, along the way, have you had all of those blood tests done? Have you had those catch-up immunisations? Have we considered all of these things? So ideally, we want it in that early resettlement period because we know it leads to better outcomes for patients, but it's always there to inform our care. Basically, it comes down to a comprehensive history, and we're so good at that, I think, in general practice, but we just really want to take that really thorough history and talking to a lot of the things that we've already discussed in prior sessions. So we really want to talk to that migration history and really understand that journey, as we've said, but then a really, really thorough medical history and psychosocial history. We want to complete a really comprehensive physical exam. I think, again, when people have different health expectations, not quite sure what we're asking of them, that physical exam becomes really important. And there are some recommended screening investigations that we need to include as well. An important component of that refugee health assessment is that we do ensure that we develop our management plan and look at referrals, and that we share with the patient a copy of that document. And there is the patients are eligible for a Medicare rebatable item number for that health assessment, as other health assessments. But again, just to, I think, really recognise that just because a patient may not be eligible for that rebate, maybe it's out of the initial resettlement period, that doesn't mean that as a clinical guideline that we shouldn't still be following the recommendations in this document. So just to touch through this, and I included there in that first slide a link to the Victorian Refugee Health Assessment template. There are many different templates that have been around over the years. They all include effectively the same content, but I think that Victorian template is a beautiful one that's a really useful resource to refer to. So I'd really encourage you to have a bit of a look at that. But at the end of the day, again, we just come back to this really thorough history. I've really highlighted, I think, throughout all of these sessions, the importance of having that general information. So when we're talking about engaging interpreters, you need to know about the patient's English skills, their languages that they speak, the order of preference around those languages. Sometimes, you might struggle to get the first language of the patient, but they actually are fluent in a second language as well, and you might be able to get an interpreter in that language. So knowing all of that can be really useful. Also recognizing that you don't want to get an interpreter in the patient's third language that they actually are not actually that fluent in. Understanding that migration history we've talked about extensively, and how important that is in terms of the delivery of care, and the kind of the resources that are available to us as clinicians and also to our patient. That social history, again, understanding household composition, who's in Australia, who's still overseas, it really shapes how we're going to engage with our patient. Perhaps the last thing that they're going to want to talk about is, cervical cancer screening when they're really, really worried about the son that they were separated from as they were coming to Australia. So you really need to understand what's going on for the family, for the patient that you're caring for, to be able to do that adequately. I also find some of those questions around, previous occupation, education, they can just be so helpful, I think, in really building that rapport and trust with the patient. The way patients will light up sometimes when you talk to them about I remember a patient, he was a photographer, back home, and whenever you spoke to him about his career, it just really. I think our roles sometimes, our occupations can be such a part of our identity, and it's so wonderful, I think, to be able to share that with somebody. So just a really important part of the history. In terms of that medical history, in many ways, this is just a really comprehensive systems review. And again, we all know how to do that, and just making sure that we're just asking all the questions, because often patients will will not know, what they're supposed to tell us and what they're not supposed to tell us. So we need to kind of really explain why we're asking the questions and make sure we are. And I think in terms of how that guides our thinking, our kind of clinical reasoning, again, we need to be thinking, about that journey. So, a fever, for somebody that's grown up in Australia, hasn't travelled recently, may well, be suggestive here of a viral infection, but for somebody who's recently arrived from overseas, it may well be malaria. We need to be thinking about that. We also need to be thinking about, again, patients' concepts and experiences of disease as well. A fever in a refugee camp can often mean something very, very different for a patient, and often a much more severe illness might always mean malaria to our patient. So when we just sort of say, yes, it's likely to be a viral illness, that doesn't necessarily mean very much to them. So we need to talk about that. Past medical history, again, some specific things to be looking to, thinking about, again, malaria, TB, any injuries, have they been in hospital, have they had transfusions, both circumcision, both male and female circumcision. Again, these can be very sensitive questions, and again, I guess I would just remind you that this is a recommended guideline that you're following, but you need to use your clinical judgment in terms of how you apply that. So some of these questions, they might be things that you discuss down the track when you've built a little bit more trust and rapport with your patient. We've talked quite a lot about mental health, social and emotional well-being, and how to explore that over time in the previous section, and then also making sure that we're considering disability and developmental or learning delays, particularly in children. And finally, we've highlighted there just preventative health. And I think, again, sometimes it's just so easy to kind of get caught up in doing this initial assessment. And then we forget all of those other things that are just so much a core part of our work. Just, remembering that at some point, perhaps not in the first consultation, but at some point, it probably, we really do need to sit down with someone and talk about, breast cancer screening and what we do here in Australia and how that fits, with our patients' expectations and trying to help them to understand the healthcare opportunities that are available here and to engage with them as they wish and when they wish. Recommended examination. Again, I mean, you can all read this, and again, it just really does come down to the really just thorough physical examination. But I think what's nice here is that this just really highlights some of those specific things, I guess, that we might not always be thinking about quite so much. So signs of micronutrient deficiency is really important when we know that people have had really sometimes limited access to adequate nutrition. The ENT and dental examination, I think it just really, I always find so important. It's amazing to me how often, I'll ask patient a general question around pain, and they'll tell me that no, they do not have any pain. And then I'll look in their mouth and sometimes they might have some terrible, caries, and I'll sort of say to them, is that not painful? And they'll say, oh, well, yes, but it's been like that for years and years and years. And I just eat on this side of my mouth, or I just eat these certain types of foods, or, we're all desperately trying to treat their iron deficiency and talking to them about diet, nutrition, all of these things. But there's a fundamental underlying problem that is making it impossible for them to kind of follow any of those recommendations. So you really do need to look. Again, just specific considerations. Pallor-murmur, consider iron, B12, folate deficiency, lead toxicity, something again that we might not otherwise sort of think about. That really, lymphadenopathy, cardiorespiratory exam, hepatosplenomegaly, again, really important. And just those injuries and evidence of torture. And again, you're kind of reflecting back on that trauma-informed care that we talked about earlier. We might not necessarily kind of talk explicitly about that injury and what led to it in the way that we might otherwise talk about an injury, but again, it might be something that we note and that we talk about over time. And just important there to note, because I think we might not always think about it, visual acuity. So African people over 40 and others over 50, we refer to optometry. I think another really common question, I guess, is is recommended investigations. I think, again, commonly it's thought that perhaps these have all been done somewhere by someone. So recognising that they probably haven't been, actually. And it's an important opportunity for you providing this medical assessment to make sure that they have all been done appropriately at some point in time. And again, I think you can probably already, kind of go through them and have a detailed look. I just talked earlier about the importance of kind of looking to those up-to-date resources, the Refugee Health Guide. We talk about the resources on the Refugee Health Network Queensland website, and you can see there often, there are recommendations around risk-based testing. And again, I think that those resources, I think another place that I really find really hugely helpful is the Royal Children's Hospital Immigrant Health Service. There's often some really great up-to-date information that's specific to specific cohorts of people arriving in Australia. So recognising, so there are the specific guidelines for people who have travelled from Syria or Afghanistan, or more recently some specific guidelines to support people that have arrived from Ukraine. So just I think just knowing that those resources are there to guide that risk-based assessment. And we've just noted down the bottom as well, just those country-based recommendations. Just remember as well that often people have transited through numerous different countries on the way to Australia. So while the country that they first fled, we might not recommend a certain screening test, they may have travelled through other countries on their journey that mean that we would recommend it. So again, to come back to Joshua, his family was a little hesitant, I guess, in the beginning, but over time very supportive care, they did decide to have that assessment done. And it reveals, and I think very important to recognise that while it's not part of the initial assessment, that right talipase is still there. It's still very much a concern for the family, and it's still there as part of our management plan and things. It's something that we need to be continuing to follow up. And I think that's what we do in general practice. We keep that ongoing comprehensive plan in our mind, and we work on it gradually over time. So that's still something we need to be thinking about. But we've now started to see that there's poor dentition, there's some cavities, so dental referral is going to be important. Joshua and his family are under-immunised. There's mild anemia with low ferritin that's been noted, and he's hepatitis B negative and not immune, but others in his family are hepatitis B positive. So we've picked up a few other things, I guess, there that we wouldn't have if we hadn't been able to discuss with the family the benefits of potentially looking at that health assessment. So as I said before, really important to give the family a copy of the health assessment, including the normal and abnormal investigations and the management plan. You only need to care for a family once who's travelled from interstate to know the importance of that. I've often seen patients that I've got colleagues in Tasmania who were providing care around the time that the family arrived. So I know that the chances are is that they've had this beautiful assessment, that they've had those investigations done. But if the family don't have any record of it, you can find yourself in a very entertaining calling around to lots of different providers to try and find those results, just again to check whether you need to be following up on some investigations that perhaps were missed in that early resettlement phase. So making sure the patient has that information, and I guess just really respecting their role in managing their own health, and ensuring that we're empowering them to have that information and to navigate our healthcare system with that information. And then follow-up is arranged. And so in our next section, we're going to build on this conversation that we've had just now, and really focus on some of the management in that sort of that early period, still just after the health assessment, and some common considerations that we see in that early resettlement period.